CME on artificial intelligence. And I'm privileged to say that we are very qualified. In this room, most of the time we have the medical CME only. So we talk about the medical science, but this is very few times we talk about anything other than medical science. So I'm happy to introduce and invite and welcome Mr. Gaurav. He's from Rosie and he has spent most of his time in artificial intelligence. So what we thought in last few months or for last few weeks, you must have gone through the social media or newspaper that whether that artificial intelligence and healthcare is really useful or it is just hype, and in between that DeepSeek comes. So I found that none other than Gaurav and his team, Ashwati and Dr. Padare, will be in the better position to guide us through next 2 to 3 hours about this artificial intelligence. And I invite Mr. Gaurav to take over from here and enlighten us about his work, how he got interested in this artificial intelligence and what is the way forward. Thank you.
Thank you, sir. I hope I'm audible to everybody on the back. Thank you. I hope everybody had a good lunch, and I'm assuming some more people are going to join us very soon as well. But without further delay, let's begin today's session. And before we begin the session, thank you, sir, for the warm welcome. The fact that we are having a technology-related health session in a CME format here is itself a sign that we are ready for more collaboration, we are ready for health AI, and we are ready to kind of jump into all of these things. Today, I have two of my colleagues as well, which we have developed this course together. So I have Ashwati from my team. She's head of our data science. She heads the AI team at Dozy. I also have Dr. Vibhor, who is the faculty and professor at IIT Indore. He teaches courses around AI and also is very invested in his particular work around AI and digital health AI. So he's also going to speak a little bit about his work and applications of health AI. I think we will go towards now what to expect from this session so that our expectations are aligned before we deep dive further for the next few hours when we are stuck together. So this course is designed to give you a working knowledge of AI. It is not designed to make you code from tomorrow. So if your expectation is that you want to start programming tomorrow and make health AI solutions, this course is a teeny tiny starting point for that, but it will not enable you to do that. What it will enable you to do is to get a working knowledge so that you can understand the concepts of AI. More importantly, you can appreciate and understand what goes into building a health AI solution. You will also understand how to evaluate a health AI solution, what is good, what is not good. When you come across a startup, when you come across a company, when you come across a research paper in your field, for example. Let's say some of you may be from radiology, some of you may be from critical care, or many other specialties. In the world today, on a daily basis, there are many more innovations going on, and people are publishing and talking about them and discussing them as well. So this course will help you to appreciate that and will also help you to understand that better on what is actually good and what is not good. It is very easy for somebody nowadays to do very limited scope of work, do not focus on it comprehensively, and still get something like a 99. Be very, very careful in terms of where you're reading, what you're taking from it, and how you're evaluating it. So this course is essentially designed to do that. Now, is this a very theoretical course where we are going to give you a lot of theory, bore you with it, a lot of mathematics and bore you with it? Not really. So we've tried to make this very interactive. So the way that we've tried to do is we've tried to focus on one example. Although we will give you many examples throughout this course, but that one example will continue throughout for the next few hours, which will be, and we've picked up a very common segment, which is if you have single lead ECG data, long lead to ECG data, how do you detect atrial fibrillation in it? How does an AI module can identify atrial fibrillation in it, right? It is something that is not related to even Dozy or not related to something that the work IIT Indore is doing. That's why we picked that neutral example and we've tried to show you in a matter of 4 hours how we can get to a very accurate solution, which through the processes of AI. So how do you define the problem statement? How do you get data? How do you clean data? How do you make sense of data? And then how do you build a solution, and how do you evaluate a solution before you deploy it? You will go through these entire steps through that example. It's a very practical example. And also, in today's course, we expect a lot of interactions from the audience as well. So we have a couple of fun tools as well in the middle. When we give you a concept, Dr. Vibhor will open up a tool where you can actually interact with us, and we'll get to see all of that interactions here. So we really expect this to be a very fun-packed, interactive session, a session of a lot of learning, where we will be able to understand the concepts of AI and also how to evaluate and appreciate these health AI solutions. The major purpose of designing this course and why we are here, I also want to kind of communicate our hidden motives also. Why are we doing this? Why are we traveling from Bangalore and Indore and coming here to do this course? Is also because you will see towards the end of this session that how only engineers or only doctors or only regulators cannot do anything. We have to come together and collaborate to build these solutions. So this course is an idea to promote that collaboration. We want to leave you with a lot of ideas from your daily practice. When you practice medicine on a daily basis, when you do your clinical practice, you come across many opportunities, many problem statements in your daily life. So this course will also give you an idea how to think about identifying which problem is worth solving, how should you go about solving it, and also what sort of help do you require for solving it. So we are interested in growing the scope of health AI beyond DOSI scope and beyond IIT Indore's current work as well. So we are open for collaboration for these projects. So we want you to come and talk to us. Our contact information will be out there. And in fact, even after the session, we can hang around for a little bit if some of you want to discuss something. But we want you to open up and discuss about the problem statements in your daily life, and then how we can develop a solution together, collaborate and together and do it. The least we will be able to do for you is, even if we don't work on it together, we will be able to give you a basic architecture, a basic strategy on this is what the steps are, this is the kind of partner you should look into, this is the kind of data gathering you should do, and these are the things that you should consider for evaluation. So we will be able to give you that actionable for sure. And then the second hidden motive for doing this course is also so that tomorrow when an Indian company or any company comes to you, clinical practice in general starts with skepticism, right? And by default, you have to assume that this new thing is not going to work, right? We are designed to kind of do that. Skepticism is very healthy and very good as well. But what we're trying to do with this course is turn a little bit of that skepticism into curiosity. We want you to ask more questions, but what questions to ask? So this course or this session will help you to arm you with which are the relevant questions. How is the relevant evaluation done? Right? So when tomorrow a small company comes or an entrepreneur comes or a startup founder comes to you and tells you, I have developed this XYZ solution, which is an AI-powered solution and which will help you with this problem. You can hear that person out, appreciate that more, ask him the right set of questions, him or her, and then be able to partner or associate with them in order to try that new solutions. Right? So that is also one of the hidden motives. While developing DOSI for the last 9 years, we've interacted with thousands and thousands of doctors, and we've seen that change. We've seen that skepticism change to curiosity, and that has led to some amazing changes even in our product. When we interact with doctors and they start asking questions from their curiosity, we get a lot of inputs and variables that we did not have earlier, and that leads to an amazing outcome. So a little bit of skepticism turned into curiosity. If we are able to do that, even for a small percentage of you, we will consider this as a success from our side. Touching up a little bit, since this course is on health AI, touching up a little bit on health AI before I invite both of my colleagues on the stage. If you essentially look, the Oxford Dictionary defines artificial intelligence, and this definition is, by the way, from 1950s. I know AI is at boom today because of ChatGPT, DeepSeek, LLMs, and all of those things, right? And now everybody's aware. But this definition actually exists from 1950s, and it is still true that the theory and development of computer systems able to perform tasks normally requiring human intelligence. That's the key part of it. Any task that requires regular human intelligence, and if a computer system is being designed to do that, for example, visual perception, so your CT scans, X-rays, speech recognition. So there are a lot of solutions now. When you give prescriptions, they will do audio to text. So when you speak, it will automatically transcribe all of it. Or decision making. So for example, you may have many clinical decision support systems where you have data coming on from your EMRs, EHRs, and may recommend you certain suggestions. Decision making and translation between languages. So let's say tomorrow, let's say a patient comes from, let's say, Saudi Arabia, and he doesn't understand Hindi or English or Marathi, and they speak in Arabic. You should be able to understand what they're trying to say, what their symptoms are, what they're actually trying to mean. And your communication could easily be translated to them as well, right? So all of these kind of examples which require basic level human intelligence, if done by a computer system, will be a part of an artificial intelligence system. The AI family is a very big family, which we have represented here. And a part of that, majority of these solutions, traditionally when in 1950s began, were regular statistics, right? By heuristics, statistics, and you will understand as we go ahead, Professor Vibhor will actually explain the different kinds of AI models. But you have the regular machine learning in it, which are basic machine learning modules, which evolved earlier. And then when scientists started becoming aware of how our brains work and started taking inspiration from there, that is when deep learning started coming up, which is trying to mimic how human brains work, how neurons talk to each other. That is how scientists started designing these deep learning solutions. And then nowadays, you actually see the AI is actually generating things. So your chat GPT, LLMs, Google Gemini, all of that is an example of generative AI, where the AI is able to generate data basis some prompt that you're able to give. So that is a subset of deep learning. Deep learning is a subset of machine learning. Machine learning itself is a subset of artificial intelligence. It may be a little bit tricky to understand all of this right now, but throughout this session, we will give you enough examples, and we will try to explain you in a format that I think we can change that understanding towards the end of this session. So with that, let me please invite my colleagues, Ashwati and Vibhor, both of them to come up. So we begin with now the process of AI. When we develop an AI solution, what is the process that we go through? So when we've thought of a problem statement already, and we will address the problem statement part of it also in the next few slides, how do we start? How is an AI module done? What is the core elements of that process? So Ashwati is going to take over from there.
Hello, good afternoon, everyone. So as Gaurav mentioned, we are now going to talk about the process of AI. You can imagine that because we are talking about learning here, so AI is artificial intelligence, right? And just like human intelligence evolves as we learn more and more, artificial intelligence also does the same. Now, how do we learn? We learn from information that we are exposed to. So that's the first step that we get there, which is that consuming the data. Now, the data in the real world is rarely clean. So even when you're dealing with, say, information that comes in tabular form in your Excel sheets, you'll see small errors like data entry errors where you'll have names misspelled and things like that, right? Similarly, any real world data would have some form of errors in it, and it requires cleaning. So that's the very first step. The next step would be a form of analysis and sampling. Now, why do we do that? Once you have the data, you've cleaned it, it's important to do some macro level analysis of what that data is. For example, for a problem that you're solving, which demographic does the data cover? What types of edge cases does it cover? And all of that. Next, we do feature engineering. We'll go a little bit more into detail of what feature engineering is. But when a model needs to learn something, it needs to understand what aspect from that data are we learning. For example, if you have an image of a ball, what are the different aspects about the ball that makes you recognize it as a ball, right? The shape, then maybe if you're talking about a specific type of ball like football, then the patterns on the ball and things like that. So these are the features that are unique about the problem that you're solving. So feature engineering is the third step for that. And then we'll come to actually building the model. So once you've identified the features, what type of model to build? Again, we'll cover it in depth in our successive slides. And once you have a base level of model, which is the algorithm that performs well to some extent, it may not often be the best possible solution for the problem. So there's something known as hyperparameter optimization where we start tuning it. So can I change a few parameters here and there to make it even more better? So if the accuracy is 95% today, can I change something about the model and push it further to 98% and so on? And lastly, this is often an iterative process, by the way. So we are saying that the last step is evaluate and compare, but when we are actually building an algorithm, this is an iterative process, because once I'm evaluating the current best model that I have, if I find that it's still not good enough to go to, say, deployment, then I'll go back. I'll change something about the model. I'll tune something further. I'll evaluate again and compare. So 3, 4, 5, 6 can often be an iterative process, which is represented in the figure as well, right? You see that it's cyclic in nature. We keep going through it. Data also keeps coming in. So imagine that you have a model today, ChatGPT, for example. You're seeing that there are model upgrades, right? Why do they happen? Because we get more and more data as time passes. So the model also undergoes upgrades. So this is always an iterative process. Yeah. Now, before we actually start this process, let's step back a little bit. Now, today, if there's something that you want a human being to build, what would you do first? So you will try to explain what you need to be built, right? That is, you will define the problem statement. And the clearer the explanation is, the better your end result looks like what you actually wanted. So here are a few examples of failures of defining a good problem statement. To the left, what you see is a juicer. So imagine this as someone saying that build me the easiest to use juicer. And this is a real world example. So this was a company that raised a lot of funds, close to $120 million in 2013. They spent the next 3 to 4 years in R&D, and in 2016 they came up with this juicer. So this was a state-of-the-art juicer. You didn't need to do anything. There was a subscription pack which will give you like pre-packed fruits. You take that pack, put in the juicer, it'll give you juice. That's it. That's all you needed to do. It was self-cleaning, a lot of things. It was also cold-pressed juicing, so apparently like the nutritional benefits are still intact and all of it, but it was priced as $700. And then obviously nobody was buying it. An year into production, the price dropped to $300, and within just 18 months, the company had to shut it. Similarly, to your right, you have another failure case. Imagine someone asking a carpenter to build a door with a latch without really mentioning what kind of door, a hinge door, a sliding door. So a latch is not really the solution here, right? We're talking about a locking mechanism. These are just examples where we are showing you that defining a clear problem statement is very important to arrive at a desirable outcome. And the same holds true even for AI models. So let's start by discussing what are the usual components of a problem statement. So there are 3 categories here. One is context and background. Within context and background is where we define where does the problem state exist. So general industry, for example. So Gaurav mentioned AFib detector that we'll work on today, right? So the area here would be healthcare. And who is affected by it? Who are the stakeholders involved? What is the current state of affairs? Because it could be a problem that is completely new. It could be something that has some partial solutions present today. So just understanding for this current problem, what is the kind of solutions that exist? What are the current state of affairs? Then gaps. So assuming that there are problems that exist, what are the unmet needs? What are the existing solutions, and why exactly are they problematic? So why are they not completely solving the problem in hand? And why is this an important problem to solve? Because in the world, we all know there are like a million problems to solve, right? Why should we pick this one right now? Why is this one so important to be solved right now? And lastly, the focus and the scope. So whenever we are talking about a problem, it can be very broad. But when we are building something, we have to narrow down our scope and pick something very specific. Because this is an artificial system, we have to narrow down, and then we have to, you must have seen technical specifications, right? Specification doc with the equipments that you deal with. So similarly, here we have to define that if we are talking about AFib, what is the exact use case that we want this model to address? And clearly define what is excluded, so what is out of scope for the model. And then lastly, we also have to define a measurable desired outcome, because AI models are nothing but statistical machines under the hood, right? So there has to be a quantifiable parameter for it to learn and keep improving. For our AFib example, like I said, under context and background, where does the problem exist? Healthcare. Who is affected by it? Patients are affected by this problem. Healthcare providers are affected. Researchers are also stakeholders here. What is the current state of affairs? AFib in itself is a common arrhythmia, and there are solutions. So it's not like it's a problem that no one has ventured into solving, right? So there are problems that exist, but with some limitations. Now, what are the gaps? So we need, what are the unmet needs? We need something that is convenient, continuous, and accurate in AFib detection. What are the existing solutions, and why are they insufficient? So we have 12-lead ECG monitoring, but it's not very convenient, right? And because of it, we also cannot have longer recordings with 12-lead ECG. So we'll have shorter recording windows. On the other hand, we have Holters, where we can have longer recordings, but then again, it is not, the ease of use is not as much, which is where your ECG patches come into picture, which are slightly more user-friendly, and ease of use is definitely there, but there still needs to be a very accurate AFib detector that uses single-lead ECG patch data. Now, why is this an important problem to solve? Because like I said, AFib is a common arrhythmia. And by 2030, the projection is that 12 million people will have AFib. This is coming from the AHI website. Now coming to focus and scope. So in the broader problem, what is the specific aspect that we are focusing on today? It is AFib detection with single-lead ECG data. Now what is excluded? So because we are talking about the AI model development, it is a small part of the larger problem of AFib detection, right? So this discussion today does not include conversations around integrations with hospital processes or clinical trials or regulatory approvals. Our scope today is just building the model. Now, what is the measurable outcome? We'll go into a little bit more detail there, but before that, I also want you to focus on the first two sections, which is the context and background and gaps. These are the things that drive human decisions to build an AI model. So based on this is what is how we decide whether this is a problem that requires a solution and requires a solution right now. And the last bit, the focus and scope, is something that drives AI model to train, better, learn, and optimize. Coming to the measurable outcome, we have a few examples here. So you see the first example simply says, detect AFib using single-lead ECG. Now the problem with that is it is too vague. So there is no clarity on what sort of accuracy are we looking for, right? Similarly, the next example does mention accuracy. So it says detect AFib using single-lead ECG with an accuracy of 90%. Here the problem is that we're not specifically talking about sensitivity or specificity. So I could build a model that basically tags everything as AFib, 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 and if my data itself is skewed such that most of the test data points are coming from actual AFibs patients, then I'll get very good accuracy, right? Because I am calling every segment as AFib, and the test set is also coming from patients who have atrial fibrillation, then I'll have very good accuracy. So Which is why, coming to the third example, we are not just talking about accuracy. We are saying that the solution should have an accuracy, sensitivity, and specificity of at least 96%. We also mentioned that these are over 30-second single-lead ECG epochs. And we don't stop at that also. We also mentioned something about the test data. So we are saying that the test data should have at least 10,000 data points, and at least 3,000 of them should be AFib subjects. So that precisely is our goal for today. That is what we'll build today.
So this particular part is very, very important. The last section, because this is a comprehensive problem statement on the basis of which we can actually evaluate something. So when we are actually saying that I'm only going to give you a 30-second segment, you have to find whether there is an atrial fibrillation event in that 30-second or not. I'm also going to tell you that the data that I'm going to test will have a balanced set of data with AFib and without AFib, so that you can actually see whether it's actually giving false alerts or whether it's false positives or false negatives. You can actually see a balanced approach there as well. And it is also clarifying that I'm also going to look at sensitivity, specificity, accuracy, precision recall all together. So it's actually a very comprehensive problem statement, and whatever answer comes out of the model will be evaluated on all of this. This data, this is the metric, right? And this is how you get to solutions that are actually ready for trials in production or ready for usage in the field today with healthcare professionals, with hospitals, on live patients, right? The above two statements are how engineers start. So if an engineer was starting it, they would just pick up whatever data was available. They would just build their analysis on whatever data was available. And then they would just focus on one metric that, see, I'm able to get good accuracy. And they would say, my solution is ready. And that is how, in my earlier context that I was mentioning, that you will find a lot of research papers in good journals where they will say very high accuracy. But are these details very clear out or not? Where is the solution skewed? Is it highly specific? Is it highly sensitive? What sort of a data set was used? Was it balanced or not? Okay, what is the window? If, let's say, for example, you need a real-time detection of AFib, and the model says, no, I need 1 hour of data minimum, right? So then that is useless. So that is why it is very important to define these things. And keeping that in mind, we want all of us to take like a very small 1-minute break. And what we want to do is actually think of your day-to-day life, and can you define a problem statement to that detail, or how much ever detail. And then if 1 or 2 people can volunteer and maybe talk about like their problem statements, right? That is something that I think we all can appreciate and think, okay, that is coming from day-to-day life of a clinician. So if you can take a 1-minute break and attempt on how would you define a problem statement that you would want an AI solution for. And try it. Like, so this might also be the first time you are thinking from that perspective that, okay, I have to give a brief to a technology provider or a technology solution, and this is what you should satisfy. Anything. It can be anything. It can be as simple as, for example, there is a mundane process in your daily life that you would like to automate so that you can focus on patient care more. It can save your time.
Which way the traffic is there so that I can reach the hospital earlier. So from home you go to the hospital, from hospital you go to the home or clinic. Which way I need to go so that the time spent is less actually. That is one of, in addition to the medical.
Like we have a lot of prescription errors sometimes because when we write the drug charts manually. So with that, whether there can be an AI solution to minimize those errors?
Absolutely. Now, when you pick that thing up, you need to essentially look at what is the input here, right? So today, as you mentioned, today you would be writing prescriptions on paper, and then somebody would be, prescription errors mean what? For example, somebody's interpreting the handwritten wrong,
Yes.
or somebody's keying in wrong.
Sometimes there might be a spelling mistake.
Correct.
Or sometimes the dose might be written a little differently. So.
Correct. So maybe a text-to-speech algorithm when you're dictating a prescription which is trained on medical data. So it understands all of these molecules, drugs, and whatever. Maybe when it's transcribing, it can actually transcribe and make a digital prescription, which has very less scope of error. But then we can define exactly that, okay, what is the error rates that you're okay with? Right? So for example, prescription and translation, it will also have some errors at some point of time, right? So how would you correct them? What would be the level? So would you want it 99% accurate? Would you want it, no, 1 in 1,000 words can be wrong, I'm okay with it, right? Or is 1 in 100 words wrong, you're okay with it. So these are the kind of dimensions that you need to start thinking when you go from a very high level problem statement to a very low level problem statement, which is from where a solution can start. So the step between a very high level, as you exactly said, there are prescription errors or translation errors. Now, any engineers thinking of that problem cannot build a solution unless we start specifying, this is the specification that I need. Only 1 in 1,000 should be wrong, or only 1 in 10,000 should be wrong. Or it should be like a text-to-speech conversion where automatic digitization should happen. You may actually add another thing. It should directly go into EMR as well, right? Because you already have the timestamp, you already have everything information. Why should I waste my time putting it in? It should automatically go, right? So all of these things are details where you need to start thinking about before that goes to an engineer and that engineer starts working on a solution like that. Yes. Yes.
I'm sorry I joined late, so I don't know what all has been discussed. But I'm a pediatrician and I see a lot of children. And many of these children come to OPD with acute illness, predominantly fever, what we label as acute febrile illness. Fortunately, majority of them are suffering from your routine garden variety viral infections. And there are certain clinical criteria which you apply and you say that this is unlikely to be bacterial and you give only symptomatic treatment. In what way can AI help me, populate this or propagate this, and can there be a, one solution? Say you feed in this data and this, okay, look, this child looks like a non-bacterial, don't prescribe an antibiotic. A specific clinical situation I'm giving.
Perfect. So this, what you're describing right now seems like a clinical decision support system.
Yeah.
So which has many inputs. So it could have lab reports, it could have vital signs, it could have, for example, the history of the patient itself and things like that, age, gender, demographics and everything. And based on all of this, what you essentially can do is, from your practice of, let's say, last decade or so, and if you already have all of these digital records or even manual records, you would basically want to digitize, make a solution that does a level of triaging. So essentially, from the knowledge of the last 10 years of information that we have, we can train models to identify when such information is available. This is the most possible or most applicable approach that has been taken in history. Right? Now the treating doctor has that as a guideline, but would need to verify before treatment. But it could give a very clear criteria and triage people that these are the people you may need to look at first, because these are not your regular garden variety infections and these may be something serious. So it may actually help you prioritize care basis the triaging. But at the end of the day, the decision has to be done by the clinician. It could help with all of these additional pieces of information. In fact, clinical decision support system nowadays are going to that level that based on the level of information that they would have, you can actually automate requesting further investigation as well before a clinician comes. So for example, let's say there is XYZ information available. Now you would want to do, let's say, a profile of any sort of an infection or a blood culture. I'm assuming here because I'm from the technology background. That could be automated, that order, so that before you come and look at it, all the information is right there as well.
No, I mean, to take it further, see, you have clinical history, examination findings, laboratory support, and the reports. There one does not need an AI to tell you that, okay, look, I'm dealing with this problem. The problem comes when we need to find a clinical symptom and sign-based solution. And then ultimately, you have that disclaimer that ultimately it is in the clinician's code to take the ball is in the clinician's code to take a call on it. So can there be a, I will not say 100% accurate, but close to 100% accurate solution with the help of AI? If I say feed in data that, okay, these are the clinical clues which is likely to make this patient having a non-bacterial infection where an antibody is not required. I'm just giving an example.
Yes,
so is that feasible? And if that is feasible, then I can say we are almost close to AI replacing human beings.
So, not. So I'll give you an example that is feasible, definitely feasible. But I was very clear in mentioning that the clinician has to take the final call, because in healthcare, autonomous decision making is something which I think the regulator also prohibits, and rightly so, right? Because you're dealing with human life at the end of the day. I'll give you an example for IBM long ago, before all of this AI boom, had a model called Watson, which was very capable of natural language processing. In fact, there used to be a game called Jeopardy on US television, where that model participated and beat all human beings. So naturally they said, okay, our model is very good with text and learning information from the text. So they fed it 3,000 oncology journals. Right now it has all the disease progressions of oncology journals, where this kind of patient, this kind of symptoms, this was the final, like this chemotherapy was done or this treatment was done. And IBM actually built a solution. It did not take off, and I'm sure they're still working on it. But they finally built a solution, and they tried it in hospitals, where now it partners with your EMR, or it attaches to your EMR. A new patient comes and all of their information is there. It suggests that this is based on so-and-so journal, based on so-and-so previous histories, this is the course of action that you should take. But now let's say the clinician decides, the oncologist decides that I don't want to do this. They can actually overwrite and say that, no, I don't want to do this, I want to do this. And it would take that into account and add it to its data set as well. So there are feasible solutions for sure, where AI and humans can learn together in real time as well, which is not very, like throughout the course you will actually understand that's called reinforcement learning if it's done real time. It's not very, let's say, encouraged in healthcare by any of the regulators, FDA or ICMR or anybody else. But there are these possibilities that are essentially out there as well.
So, but I mean, I personally feel that AI is here to stay, and it is being increasingly used even by medical professionals. The only potential help that I find is, like, there are set protocols, there are set guidelines, which are made for clinicians, but unfortunately they are not implemented. No matter, because adult teaching and learning is very difficult. So if an easily accessible AI solution is available, maybe it will help us percolate and ensure that these guidelines reach and applied by the clinicians. That's the only.
So the work of AI there is, and I think when we go through with the session today, you'll understand what are the pitfalls of AI, where actually AI fails, right? I'll give you a very small example right now, which I think you'll be able to appreciate next in the session. This is actually from my personal experience with my niece, nothing to do with healthcare. The way an AI model learns is with the information that it essentially gets, and it is very easily possible to draw biases. And this is how humans also learn, but humans evolve much more quickly. I have a niece who was 3 years old recently, and she's based in Pune. I was there for her birthday, and I wanted to buy her a soft toy. So I found a very nice penguin, a soft toy penguin, and I gifted it to her. She was very happy, but her reaction shocked me. Her reaction was Kung Fu Panda. White, black, soft, fluffy, Kung Fu Panda, right? So her brain had trained on, like she had seen those movies. She loved Kung Fu Panda. In her mind, anything round, anything white and black, soft, fluffy is Panda itself. Now it doesn't matter whether it is penguin or not, right? So now her brain has gotten new information. Okay, this is a penguin. And that is exactly where edge cases, AI is not really a good solution to basically rely on right now. Even when nowadays you would read, for example, AI is replacing programmers as well, because AI started writing code as well. We don't allow code to go into production without a human review, right? Because it's not 100% reliable. And when you're dealing with human life, I think it's the last thing where talking about replacing doctors or nurses or other healthcare professionals, I think that would be the last thing. What would be replaced is doctors that use AI could replace doctors who don't. So that's why a basic framework, so that today if you look at 10 patients, how do I make sure that you look at 20 patients that efficiently? How can I save more of your time? So with those triaging solutions, how can I lay out everything in front of you so that it's super easy that when you go and check, this is the recommendation, these are the data that are available, and from your human judgment, you can actually do faster analysis and faster treatments. So that is, in my opinion, the job of AI. But then again, let's go through ahead with the session today.
One more point there, because we were talking about problem statements and specifications for problem statement, we spoke of accuracy, but there is a trade-off with time to build also. So ma'am, you mentioned the prescription errors, right? So we may say that it make only one out of 1,000 errors. But if the problem is so grave in the sense that it is so rampant and you want a solution in say 2 months, then maybe there would be a trade-off that, okay, I am okay with having 10 mistakes in 1,000 prescriptions, but I want a solution in 2 weeks or 2 months or so on. So that's also a trade-off that we can describe when defining the problem statement itself, that give me a solution which is moderately good in this time frame, and then something that is like much better in a longer term time frame.
Yeah. Thanks for all the inputs, and I think great question. I cover a part in this where I talk about what essentially learning means. But before I go on to the next slide, I want to ask a few questions. So we are all here for learning about AI, right? And from background, I am a mechanical engineer. I'm not a data scientist per se, or I don't come from a computer science background. But I'm here and I'm working in the field of AI for the past 12 years. I'm very happy to see all of us. Anyone here who is a computer scientist? No, right? So not coming from computer science background, but being here to learn about AI, I think is a big deal. And we'll see why. Another question, how many of us are 100% familiar with AI over here? Raise your hands. 100% know what AI is. 80%? 60? Few hands, 60? 50%? Okay. 30%? 10%? Okay. 10% and then 0%. Okay. 10% is great. Can you tell me some of the examples that you have seen of AI in your daily life that has brought you over here? It doesn't need to be health. Anything AI that you feel is AI and has brought you here. Google? Google Maps? What else? ChatGPT? Fans of ChatGPT, raise your hands. Gemini, Google Gemini. What else? What is DeepSeek? It's an LLM model, okay. Why DeepSeek became so popular suddenly? Okay, I think we have people in the 80% category here. Okay. What else? What other examples? Cloud AI? Cloud AI. Okay. What else? Simpler examples. Simpler examples. You use our face recognition to unlock our phones? That is an example of AI. DigiYatra is an example of AI, right? So you see how AI is starting to percolate in our daily lives, in travel, in our payments, and anything that we do. And wouldn't it be nice for us to use this AI for one of the biggest role as we play in human history is in healthcare, right? So I'm a big fan of trying to help doctors. So that's why I chose to move away from mechanical side of things. So till now, a long time I spent in working with machines and detecting when a machine is going to fail. And then I realized that it's much better to replace that machine with a human, which is also a kind of machine. So also, excuse me for all the jokes, I'm not a doctor and all of us are doctors. So if I say something which is not suited for here, but I kind of compare as systems. So I work with systems, I'm a systems engineer. So I work with systems and I look at human beings also as a complex system, just like we have complex machinery, right? So my point being that it is great to be here and learn about what all AI can do. This is also what I do, and this is what Gaurav started in the beginning, that we want people from domain to tell us what else we can do to help and give back to the world, right? So coming to the next part, and I have more things on the AI side, but nothing is possible without data. So if you look at AI is nothing but if you look at a baby growing up, the biggest example of intelligence with all of us is ourselves. Our brain is the biggest example of intelligence. If you see a baby, it doesn't know anything, it is born, and over time it learns all that they have to learn, and they become intelligent, right? How do they become intelligent? Just guesses. By learning. How do they learn? What is the way of interaction? Observation, through interactions, through experiences, right? When we talk about artificial intelligence also, data becomes one of the most critical aspect, right? So here, when we talk about healthcare, you can see that the data comes from so many different backgrounds. Someone gave an example of prescriptions. Prescription also, handwritten prescription, digitized prescription, lot of different forms of the way data is collected is an important source for any AI in healthcare to make decisions. Images, when you go for any CT scan, any X-rays, any of that, that is a type of data which is used. Data which is coming through sensors. Dozy's example where you have sensors installed in the bed, you get data from there. You have data which is coming from laboratory. You have data coming from genomic genes on that side. You have data on the demography of the patient. All of this data comes together, can come together to build real world impactful AI solutions. That is where the world is heading towards. So I'm trying to give certain background on where AI is going, and the biggest direction over there in which I am really interested in is digital twins. Anyone who has heard the name digital twins? So I'll tell you what, or can you guess what digital twins are? Just simply by the name. It has two terms, right? One is digital and one is twins. What are twins? Replication, correct? What is digital? Online, which is information based, or digital, which is not in the physical world, right? So digital twins simply means behavioral models which are based on real-time data connections, in which data is coming in real time, interacting in real time, and it has feedback. So basically what digital twins mean is we are trying to create that AI which is continuously learning and able to feed back to the user, right? How is this useful? This is our world. This is our physical world. What do we have? If we look at from a healthcare perspective, this is us. This is one of us. What all devices do we interact with? If we need any healthcare, we go into the hospital and we have certain measurements done, we have certain medicines which we get, right? If we are not in the hospital, if we are living our life, we may be doing some exercises, the type of food we eat, the area in which we live. And then we have certain other people also who are there. All of this information, together with what we saw in the previous slide, can be built together to build a model which behaves as we would behave. Ultimately, when we go to anyone comes to you to a doctor, we tell our symptoms like this is what is happening, that is what is happening, right? Similarly, that behavior could be predicted using all of this data. When we try to make any decisions, what do? We look at our learning, which we have learned over time from all the cases that we have seen, all the research that we have studied, and use that and see where it fits and gives a decision, right? Similarly, in the digital twin, all this information get transformed as numbers, as graphs, as percentages, quantified into a certain patterns, which tell us how I am going to behave. This is a digital twin of me, right? And then when it comes to making decisions, you just don't have a digital twin of one person, but you basically have a network of digital twins in which you can see that my profile, the background which I come from, the history that I come from, may be similar to someone else. And if that person is developing something, there are high chances that I may also develop something like this. Can you give an example of something like this in our regular life? Anyone Instagram users or Facebook users? Raise your hands. How are we doing doom scrolling? We continuously use our phones, right? Why? Why are we able to continuously get the content which we like one after the other? It is because of such recommendation algorithms which are able to tell that this user is consuming this content, other users have also consumed this content and has consumed another content which they like, so maybe I will also like that. Similar concept is what can also be used in a network of digital twins, which then can come back and help us in making better decisions for patients, right? So then coming a little bit closer onto what all can be possible over here. So a quick summary, and this is more on a healthcare perspective, if we go in depth. So you have the real world where you have the patient, you are monitoring treatment, diagnosis, physical examination, a lot of actions that happen in the physical space. You compare, you model them or you map them into the virtual world where you have vital physiological parameters, radiological images, genotype, other things, you have EHRs, all this information. What do you do with all of this? This is where you fit in your AI, your data analytics, anything that you want to do, the learning part. Now, learning is not just very simple learning, as I think we mentioned, there are protocols, there are things which needs to be followed. All of that come over here into the analytics pipeline. And then you also need to maintain them, like cloud AI, not cloud AI, but when you have clouds and services which provides you like ChatGPT, they have to be stored, they have to be maintained. And this is where government can play a huge role like they're doing with DigiYatra and UPI and other stuff. And then this is where we all come over here, where the users, medical practitioner, lab technicians, pharmacy, medical insurance agency, digital twin payers, device diagnostic tool providers, service providers, for all of us, we can do better outcomes, better treatment plans, personalized medicine, surgical planning, training, a lot of things that can happen. You see how we went from data, which is literally a multifarious data, to converting into the digital form, building models, maintaining them, finding out the user, like she mentioned, what is it that's in for me, what is the specific problem, to going into the final benefit that we can get. So this is what we are going to learn about. And then let's go a little bit in depth into a specific example where Ashwati can take up.
So we'll start with raw data and label visualization. What I mean by raw data is just the information that is presented to the model itself. And the label is what it is that we want the model to learn. For example, in these scans, this is the raw data. The scan itself is the raw data. And the labels, benign or malignant, those are the labels that we eventually want an AI model to learn, right? This is an example of our sensor, the DOSI sensor data, and we'll see, one second. Yeah, and these are examples for our problem statement today. So like we discussed previously, the problem statement for today revolves around AFib detection using single lead ECG data, right? So these are just examples of 30-second epochs of single lead ECG data, and these are the labels. So one is an example of a normal subject, and the other is someone who suffers from atrial fibrillation.
So to add to this, how do we know that is normal and how do we know that is AFib? Right? How do we know that actually? So there is a trained technician, there is somebody who's trained in this, who obviously understands the physiology and electrophysiology particularly, and has been certified to mark this. So we'll look at it. Based on their trainings, their brain would say, okay, this is normal because that is pretty regular. And then there are certain features in that they would see from their training and they would say, no, this is atrial fibrillation. Now we are going back to the first slide that I presented, which contained the definition of AI. Any task that a computer is being designed to do that requires some human level intelligence. So I don't know how many decades we've spent. The ECG was invented in 1903, but I'm assuming a little after that, when we figured out there are arrhythmias and then there are atrial fibrillation, somebody coded it that, okay, this is the particular way an AFib is identified and diagnosed, and then created a course. Humans started learning it and now started marking it. So it requires certain human level intelligence. And if AI starts doing it, or if a computer model starts doing it, it comes into the realm of AI. And as Vibhor was mentioning about digital twins, this is an example. So let's say if there is a patient with a single lead ECG data, throughout that data is coming to, let's say, a platform. In his layer, if you remember, there was data, then there was some sort of a platform, and then the model is interacting with that platform, and then there is a prediction being made that this patient has atrial fibrillation, and with this frequency. So somebody should look into this. That is a component of a small part of digital twin, right? Which also brings me to, we have a very, again, we'll take a very quick break here, and we'll do a very fun quiz here where we can, Vibhor can actually facilitate that, where you can actually now participate. From whatever you would have understood about digital twins right now, a small quiz related to that. So for this, you may have to interact with us a little bit.
Check. Sorry, I'm a teacher, so I like taking quizzes, and we all have to participate. What you have to do is, you have to take out your phones, and either scan this code, which is just going to come up over here, that QR, and it will take you to the game, or you can go to kahoot.it and just enter the game pin.
So that is KAHOOT.IT. If you cannot scan it, please go to the website KAHOOIT and then put that pin into that website.
Perfect. We can see people joining.
So somebody did not put the name, somebody put the name. So
You're free to put whatever names, basically.
yeah, you can put Iron Man also.
Yeah, you can get creative.
Yeah, Professor X.
Or Elon Musk.
So we have.
I'll repeat, KAHOOT.IT.
Right now we are getting serious here, I can see. Kejriwal lost. Are people at the back able to see? Yeah? Anyone needs help logging in or joining the game? You can just enter the game pin as well. They just have to put the game. I think we are more than 50 people in the room. So we'll definitely wait for the number to hit 50. We are at 15 right now.
Please let us know if you need help. We have a team that can help you as well.
Dozy.
Oh. Right, 26. How many of you are done? Okay, how many of you are still doing? Okay, we'll take another couple of minutes. We'll wait for it to hit the 50 mark. Too bad they don't let us choose the emoji. We are at 30. You need some help?
Yeah, there.
Yes. You can just hit join the game and put the pin that is shown. So we're at 34. Let's take another minute. All right, everyone who has joined, we have all watched Kaun Banega Crorepati? Yes? In that, the first part is fastest fingers first, right? Everyone familiar with that? So this is similar to that, wherein what will happen is the question and the options will appear on this screen. Simple one-line question and 4 options. Each option will have a different color and a different shape, like a diamond, square, triangle, and circle. On your screen, you will only see these 4 options as 4 buttons. Okay? As soon as the question comes up and the options come up, you have to answer not only a correct answer, correct option, but also the fastest. Get it? So, the faster you answer, the more points you get. And then after each question, we'll show the leaderboard. All right? I think we are at 44. We should be good. Anyone needs another second, or should we go ahead? Okay. So let's hit the start button. Yes, if they know the code. Right? So the first question is coming up. We have to pay attention to the screen. So it's a quiz. What can we achieve using a digital twin? The options are here. And you have 30 seconds to answer. So we have 36, 37, 38, 39, 40, 41. Perfect. So now everyone gets it. So the correct answer is all of the above. And we can see that 30 of us answered it correctly. So digital twins don't need to just be in the healthcare domain. They are basically behavioral models which can be applied throughout any application area. Right? Let's see the leaderboard. So Kejriwal won. All right, everyone got the hang of it? Let's go to the next question. Which of the following technologies support digital twin? These are very easy questions, no?
You want to read the options in Amitabh Bachchan's voice?
No, thank you. Waiting for one more person, probably, or two. All right, everything needs to be there for digital twin. It's not just the AI part, but also like IoT, cloud, and also on. Yeah. So we can see most of us focused on just the AI, but as you will see throughout in the lecture, there are more things which are needed. Still winning? What is a real-time digital twin? A twin that updates only once after a week, instantly as the physical object changes, does not require a physical counterpart, built for virtual reality gaming. Awesome. So I think then this also helps us know that whatever we are telling is being received well. It is a digital twin that is updated instantly. So there are different frequencies in which data can be collected, and this is one which is real time.
Question.
Yes. Oh, in the class here? Okay, I will definitely do that next time. Right now? Okay, okay. Oh, I didn't know that. It's very helpful. See, we are continuously learning. So maybe in the next question it is possible. Okay, Akshay is on the lead. Last question. What is the primary goal of predictive technologies? Is the options coming on the screen? Perfect. Thank you. Awesome. Okay, 15 people who answered to replace human intelligence. No. Okay. So it is to forecast future trends based on data. Now the data can be any type of data, but that is basically what predictive technologies are for. Just take a minute to see who won. Let's look at the podium. We have Joy at number 3rd. Blocked.
Number 2.
Akshay. Can we have Akshay stand up, please? Big round of applause for Akshay. Awesome. So let's continue. We'll have another round of quiz after another session. So make sure you are paying attention and also feel free to ask questions as we go ahead. Yeah?
So there is one more quiz after one more session. So please pay attention.
Handing it
So coming back to
over
our AFib
Ashwati.
example, now we're going to pick up AFib as we mentioned. So Ashwati, please, let's continue.
Yeah. So we'll start directly with the first step, which is data cleaning, right? So here on the top that you see is the raw signal coming in from the ECG sensor. You can see that there is a baseline drift, right? So this is possibly while the subject was moving around maybe, or too much movement. So you see, do you see this drift slightly here? And there's some artifact here as well. This is not the best data to feed into the model because there is some information here which is not pertinent or not useful for AFib detection itself. So we want to clean it up and we want to give the model only what is really necessary for the problem at hand. That's the first step that we do. So you see that this signal, which is cleaned from the original raw signal, does not have that baseline drift that we saw here there. And it has also, to some extent, removed this artifact. Yeah?
This is exactly what a human technician is also doing, right? So when you have the Holter data coming into a technician, when technician is looking at it and there is an artifact, and they know that it can be because the electrode moved a little bit, patient moved a little bit, in their mind, they're ignoring that particular part of data. They're not essentially thinking too much about it, and they're focusing on what they can see in regular sinus rhythm, on what they think where they can identify any sort of an arrhythmia. So this is in a way replicating that, but the first step, as Ashwati mentioned, is about how do I remove unnecessary information that is not related to AFib from the data before giving it to any machine learning model, right? So what we're trying to do is we're trying to clean up the data as much as possible to the relevance of our problem. Our problem is AFib. The baseline drift in an ECG does not get affected by AFib. It can get affected by body movements. It can get affected by anything. So our first step is to remove that sort of a drift. And so we've used digital techniques to remove that sort of a noise and a baseline. And what you get is a very clean, very steady ECG signal that you can now do further analysis on.
And if we were to explain this even with like a real world, a simpler example, imagine that you're building a model that wants to detect an activity, 2 types of activity, that whether a person whose image is being looked at is sitting or dancing. Now imagine the data that the model may have been trained on. So very likely the images of dancing, not true anymore, but could have some blur. So as someone is moving and you're taking an image, very likely that the image would be little blurred, while the images that are of a person sitting will be more clear. Now, if we feed that data as is to the model, instead of learning sitting versus dancing, the model may end up learning clear picture versus blurred picture. So next time you feed it an image, a blurry image of a person sitting, it is possible that the model will call it dancing.
So I have another example here, exactly on the same example. Let's say the people who were dancing in those photos all wore red colored clothes, all of them. And people who were sitting all wore green colored clothes, right? So now next time you give the model a green colored clothed person dancing, it may actually say sitting, because it picked up a perfect thing of red color means dancing, green means sitting. So now, if I were to build that model, what I would do is I would say color is irrelevant to sitting or dancing. So I would make all the colors or all the images black and white before giving it to the model, so that it doesn't get biased on things that are not related to sitting and dancing, right? Which may be skewed in my data.
Next, we'll move to a step called exploratory data analysis. This is where, simply put, we just look at the data. So that is how we learn and human intelligence grows, right? As we are observing, learning from the data. So we sit and actually observe what it is in the data that makes one distinguishable from the other. So you have normal ECG and AFib ECG sample. What is it about AFib ECG that makes it different from the normal? So we know that in this room we have all doctors, but if you could put that hat aside and just as a human being looking at these two images, what are the stark differences you see between the two?
The bottom image is pretty irregular, right? The top image is quite regular. And that is the major difference that you essentially see. What I like to call this phase of exploratory data analysis, how many of you are Sherlock Holmes fans? Or have at least seen movies or TV series or at least read books? Sherlock Holmes, anybody? A lot of people? So there is a part in Sherlock Holmes novels and movies where Sherlock Holmes gets stuck. And what he does is he sits on the floor and puts all the evidences in front of him. Right? Whatever data that is collected, there are books, there are evidences, he writes and scribbles and everything that he knows in front of him, right? And he tries to focus. This is exactly that phase. What Sherlock Holmes in his mind is exploring that data that he's put in front of himself, exploring that data and analyzing it. So when, as an engineer and as a doctor, if you give us that problem statement, detect AFib in ECG, our first step will be, can I sit on the floor? Can I put all normal ECGs on one side? Can I put all abnormal ECGs on one side? And can I see with my naked eyes, is there a difference in between the two or not? Because remember, I am not a doctor, right? This step also involves interacting with the doctors. So it's not necessary that I from the naked eye needs to see, but as a doctor, can you explain in physiology that what is different? Exactly what is different? A similar could be, for example, ST elevated myocardial infarction. So can a doctor explain to an engineer what is S wave, what is T wave, and what happens when ST gets elongated, right? So exactly that sort of a translation from physiology, from your understanding of human intelligence to basically features that can actually translate into numbers. And that becomes the problem statement here, that regularity versus irregularity is something that I need to, it becomes very clear to me, relevance for this particular problem statement is regularity versus irregularity.
This is just a code base that does the same thing that we saw earlier. So you have raw data here, and then through signal processing, we clean it, and we get the clean signal here. Yeah. Next, we mentioned that, so this is the floor, Sherlock Holmes putting all the data on the floor sort of scenario, where we plot a lot of normal ECG samples and look at them against the ECG samples. And here it becomes more apparent, right? You see the irregularity in the bottom section versus the more regular heartbeats on the top. Yeah. Now, so we know now that irregular rhythm is what we want to try and quantify and capture. So we start by actually building up code that can detect these heartbeats. So that is step one, because if we want to capture regularity or irregularity, we have to first identify the peaks itself. So we did that. The next is thinking of a measure. So how, now there is irregularity, that's just a quality that we are talking about, right? But for the model, we need to quantify it. So there has to be a metric that, sort of benchmarks irregularity. So that is where we look at domain expertise, domain knowledge. So we do some literature survey and see what are the sort of metrics that we can use. So we found the PNN metric, so PNN 50, that is often used for heart rate variability. But we tweaked it because PNN 50 is defined over a 50 millisecond window. We don't want to define it for a fixed window because heart rate of a patient or a subject may vary. So if someone has high heart rate, we want to look at smaller windows because they already have high heart rate. So so in a small window, they'll have enough heartbeats for us to quantify irregularity. Whereas someone with low heart rate, we look at larger windows. So we define X based on the heart rate of the subject itself, and then the PNN is the usual ratio that exists for HRV. So we've computed these features for the subjects, and then we start visualizing. So visualizing allows us to understand if the hypothesis that we had, that this feature is a useful feature, whether it is true or no. So what is this visualization? This is called a scatter plot. In the x-axis, what you have is the value itself, the value of the feature for various subjects. These dots that you see are nothing but the different subjects. So this is the PNNX for one subject, for another subject, and so on. Everything that is in orange is of normal subjects. Everything that's in blue is for subjects with AFib. Now this has a clear discouraging message right here, because what I had hoped is that this metric will allow me to distinguish between normal and AFib. So that would have been possible if there were like a range of value that normal subjects showed versus say a different range that AFib subjects show. But this scatter plot shows us that all of them are overlapping.
So if you want to take the message from here, how did we go from Sherlock Holmes to a lot of numbers and code that you see on the screen? We figured out while looking at these graphs, talking to doctors, that regularity and irregularity is important. Now the question is, yes, we've understood that subjectively, but how do I objectify it? How do I quantify it? How do I quantify irregularity? So we did a little bit of research and we found this particular feature called PNN 50, which is used in heart rate variability, can actually quantify variations or irregularities, right? And we tweaked it a little bit. As Ashwati mentioned, we wanted to make it more generic, so we tweaked it a little bit. And now we wanted to see what is the result of our quantification. So all of those graphs that you see, each data point here represents the PNNX value of one 30-second strip, right? So each data point on your screen is that. Now the strips with normal are colored in orange, and the strips with atrial fibrillation are covered in blue. Now my problem is, I cannot distinguish between the two from x-axis. So any data scientist will be discouraged. Okay, this feature is not working, unless you start to visualize it slightly differently.
This is a different type of visualization. It is called a box plot. It shows you central tendencies. By that, what I mean is that if you see all these points, these are all genuine points from this particular class. So again, blue is AFib, and then you have normal in orange. Here also you see that these values are occupied by both. So you have these points here till as low as that. But the good news is that what this box shows is majority of these points lie here. So majority of AFib have values in this range. Majority of normal have in this range. So this is very encouraging because even if there are few points here, at least we know that central tendencies or majority of them are distinguishable.
So everybody understands box plots? Giving you a very quick overview of box plot, this central line represents a median. Median of what? As I mentioned in the previous case, each data point was the PNN value of one 30-second ECG strip. So I have a lot of ECG strips that are AFib, and I have a lot of ECG strips that are normal. Now what we've done is, instead of plotting them directly like we did in the previous graph, we've grouped them. So what is the median value of PNNX of the category of normal? What is the median value of the category of AFib? Now not just median, this represents 25 percentile, this represents 75 percentile. What that essentially means is that this thing would contain the number of data points or number of strips that are between 25 to 75%. And this one would be 95, between this and this would be 95% of the data. So only 5% of the data would be out of this. So imagine if I draw a line here at 60, where I'm able to separate both of them by 95%. So 95% of the entire ECG strips which are normal are here, and 95% of the ECG strips which are AFib are here, and my line at 60 is cutting through in the middle. That means that when I start saying, okay, if it's above 60, it's AFib. If it's below 60, it's normal. I will, yes, misdiagnose 5% in both categories, but 95% of the times my output would actually be correct. So now getting a feature that can cut your data set 95% between two categories is actually a brilliant thing for the first shot. This is the beginning of the solution, right? There will be many other ways to slice and dice the data. But if the first feature that you've built could actually do that, is a very great start.
There's one more visualization which is similar but slightly different. So this is called a violin plot. It is also showing you where majority of the data lies, but on top of it, it is also showing you the distribution. So instead of having one box there, which tells you that most of the data lies here and here, within that, it is also showing you that most of it lies here like this. So yes, these points are also included in the box, but even those are not very dense, not many points here. So this is another visualization, again very encouraging because you see that same 60 that Gaurav spoke of. Most of the segments with AFib are above it and those normal are below it. Now, see, but these are still problematic, right? It is still a problem if we start missing these segments. Similarly, it is still a problem if we misdiagnose these, if we start giving false alerts based on, or false positives based on this, which is why one feature is hardly ever enough for training a model.
Let me give you another appreciation of what she just said. One feature is never enough for a model. That is always true. Now, if I was building, let's say, a model to identify a chessboard, right? What is unique about chessboards? Alternative patterns of white and black. Can I say that? Right? So if I train a model, if there is any alternating patterns of white and black, you have to tag it as chessboard. If I make a feature, which is a score of how much of white and black next to each other, and if the score is high, it is chessboard. If the score is low, it is a chessboard. You give it a zebra crossing, it will say chessboard, right? Because you only taught it white and black alternating. So one feature is never enough. You have to now tell it, okay, white and black alternating squares, right? Then it is becoming better, right? Now it will not say zebra crossing is a chessboard. So that's why you need more dimensions. These dimensions are features for a model to look into.
Yeah. Now looking for newer features, first we started with domain knowledge. So we knew irregularities, what we wanted to quantify. We looked into research, what existed. There was heart rate variability based metrics. So we spoke of PNN. And again, PNN 50, we modified as PNNX. Now, sometimes we also need to think of cross-disciplinary features, right? So not everything may be present in the current domain knowledge. So this is where we came up with a unique feature, entropy. So entropy is commonly shows up in chemistry, physics, even information theory. Entropy is nothing but a means to quantify chaos. And here, when we are talking about irregularity, that is also chaos in some sense, right? So that's exactly what we tried to do. So we tried.
Yeah. So chaos, in other words, is randomness. So if distance between two heartbeats is very regular, it is not going to be random, right? But if it's very irregular, it's going to be random. So another word for chaos is randomness, and entropy tries to quantify that. How many people remember third law, the second law of thermodynamics? Third law, right? Yeah, third law of thermodynamics. Even I'm not able to remember second or third, but third law of thermodynamics. We all read it in, I think, 10th standard or 9th standard. Third law of thermodynamics states that the entropy of universe as a whole will always keep increasing. So the randomness in the universe, including stars and everything, will always keep increasing, right? So that's a concept from physics that we picked up, but then we brought it here saying that, okay, I need a measure of randomness. And some mathematician had made long ago that entropy is a measure of randomness. So we reuse that.
And we did the same sort of analysis, so the same sort of visualization. So here, one good news is that earlier we saw that when we were visualizing through scatter plot, all the values for normal and AFib, we saw that they were completely overlapping. In this case, one good indication is that they do not. So why that is good is that if you see values below, say, 1.4 or so, at least you can be fairly confident that those are not AFib segments. Because if it is in this region, it has to be normal subjects, very likely normal subjects. So that's a good indication. But we'll still go ahead and look at the other sort of visualizations. So here we again see that the overlap is not there. So at least most of the points are distinct, in distinct ranges. And the same with the violin plot. Yeah. The next bit is we went one step ahead. So why stop at irregularity? Because even when we were talking to clinical experts, they said that it's not just irregular rhythm, but it is irregularly irregular rhythm. So we didn't just measure the entropy of difference in time between successive RR peaks. We did a second order difference. So the difference in the difference of time and the entropy for the same.
So this is exactly classical translation of clinical knowledge into mathematics, where because an electrophysiologist was able to tell us that it is not just any irregularity, it is irregularly irregular segments that will become AFib, we were able to think, okay, I need a second order differentiator, which will basically say, okay, I need to find irregularity and I need to find irregularity in irregularity. So that's why that second order came in. Because that idea was, and this is something which is very difficult to pick up from the ECG strips ourselves, because we wouldn't understand that. But until the electrophysiologist told us, and as soon as they told us, that idea struck and we tried it.
Yep. And here too, we see a similar pattern where there are clear values which are only displayed or demonstrated by normal subjects. So at least for those segments, we can be fairly confident that these segments are normal segments. And a similar story can be seen with the other two visualizations, where most of the data points lay in different ranges. This is just a 3D visualization to show that they are distinct. So together also, when we put together these three features, there are not a lot of overlapped regions in them.
So this is another example to showcase what we just showed you for AFib. Right? This simple method of analysis can actually be applied to any domain also when you start thinking like that, right? I mentioned chessboard and zebra crossings, but let's take a more healthcare oriented problem, right? This is a very famous problem when it comes to when machine learning engineers start learning. There's a website called Kaggle, and there are these problem statements with data there, and when we go and we have to solve these. So what they've essentially done is that on that data set, they have these X-rays, and then there are basically kind of tumors that have been identified and their features. So there is radius, there's texture, there's perimeter, there's area, that's smoothness, compactness, concavity, concave point, symmetry, fractional dimension. I don't even understand half of those. Maybe a radiologist would be able to make sense of a lot of those, right? But what we essentially did for that was we said, okay, we will plot the entire segment or the entire each particular test that was done on a single sheet. And what we will do is we will plot two features. We'll focus on radius and we'll focus on texture. So when we do that, it becomes evidently clear that these yellow ones that are benign and then the red ones that are malignant, you can actually draw not really a straight line, but you can actually draw a plane, and the left side of that particular line or the curved line that you essentially see, if you start saying that everything there is essentially benign and right side is everything is malignant, you would actually end up at a solution which is almost 90-95% accurate, right? Because only 4 to 5% of wrong data points are on the either side of it. Now, these are just 2 data points. Now, when you start adding these, this same graph becomes from 2-dimensional to 3rd-dimensional. Why? Because there's another perimeter that is added. Now you add area, a 4th-dimensional, right? You start adding smoothness, another dimension. So now there is a zone where it starts going beyond a human comprehension as well. And that is exactly where machines take over. And that's why you need large amount of data sets. Right? You need thousands and thousands of data points to actually be able to replicate the value or replicate the representation in the actual field. So how these tests would look like on a population basis, in order to replicate that and learn from that, you would require these thousands and thousands of data points, and you would be able to draw that curved line. Left of it would be benign, and right of it would be malignant. So this is another example for, like if you wanted to pick up a radiology example, that could kind of, a learning solution could be developed in this particular manner. So now that we've captured these features, the next logical step is, yes, the humans are not going to look at these features and then say, okay, because these features are this, I'm going to mark this. Again, that would not be intelligence, right? The intelligence would be, can the machine basis these features self-identify what should be the label or the value, right? And that is exactly where you have neural networks and machine learning solutions, different types of machine learning solutions that you could actually apply. So Vibhor is going to cover what are the different kinds of AI solutions that are out there, models that are out there, where you can feed your data, clean your data, make understandings from that data, extract features out of that data, and then give it to these models to learn, and then use it in the field to actually perform certain sort of analysis for you, right? So we will learn a little bit about different types of models that are available, and then we will go back to the AFib case and see a couple of models on how they perform. And we will then start evaluating their performance on how well did they perform.
So what do we see over here? Can we identify this? They're neurons. Perfect. And what is this? This is artificial neurons, right? So what I'm going to talk about is why AI is becoming so popular is because we are trying to mimic how we learn, as simple as that. So we are trying to mimic what naturally occurs as neurons in our brain in a computer system. So I'm going to talk about neural networks and applications in advanced AI. What do we say is a gold standard of AI? what can be considered as the gold standard of AI? Sorry? Anything? What is it that we want to achieve with AI? When do we say that, yeah, this is what we need to achieve? To what is that benchmark? Human being, correct? When we say why Tesla is continuously upgrading, ultimately they want to reach to a point where they can be as good as humans, right? So human beings are considered as the gold standard of AI today, at least till now. Why are humans considered as the gold standard? Why are human beings intelligent? The answer lies in this, and I'm sure you know a lot more on this. I'm just trying to draw the inference over there. Why are human beings so intelligent? If you can, sorry? Why are neural networks, why is our brain so powerful? And? Ultimately, if we see over here, there is memory. If we see over here, they are networks of networks. So the same brain which is born, which I gave an example earlier, is able to learn so many different things depending on different experiences which they get, right? So what is so special about the human body? The computer scientists, the way they look at it as, it's a self-organizing complex network of networks embedded in a hierarchy of complex networks. You see how many times networks are appearing? That is where the benefit is really lying, and we are trying to just mimic that. So information is represented and processed as dynamical patterns of activity over these networks. So you have two things, right? Neural networks. So you're now talking about networks, why they are so important, that makes us so intelligent. And these networks are reconfigured continually by processes at many spatial and temporal scales. All perception, cognition, and action emerges from the activity of these networks. So that the networks are so powerful that is what is inspiring the revolution of AI. If we look at networks, what is it in the networks that makes it so powerful? The biggest aspect is the modular construction. Now, through this next 10 minutes, there will be a lot of terms and a lot of technicalities, but for me, my goal is to give the motivation or the fundamental understanding of why neural networks are being so popular and why they are so powerful. The biggest point is the modular construction, which simplifies growth, channels growth in a useful direction, makes growth more efficient, and increases stability and robustness. Right? So you can see over here the example which I gave earlier. When we detect a face, that face can be broken down into so many of these features which we talked about, which are not defined by us, which are not defined by humans, but are automatically learned. So from here, they can map a lot of points and come to a case where they can say that this is Vibhor, this is person A, this is person B, this is person C. And all of this is networks, right? So why are networks so important? And what are neural networks? If we go from that definition of what we observed about human body, neural networks are nothing but brain-inspired networks of neuron-like computational elements which are learning from data using brain-inspired and statistical methods. There's nothing else. So all we are trying to do, all data scientists, all computer scientists are trying to do, is try to build the model which can mimic brain, as simple as that. So we are learning from basically ourselves. So this is a network, and you can see a lot of different data can go in. Images, videos, text, sensor data, numerical data, whatever. And at the end, what we get out is memories, labels, translations, decisions, advice, explanation, all these things are possible. But this has been around, like Gaurav mentioned before, since 1950s. So why is it that AI is coming as a boom only today? Computation? There are 4 major factors. The first one is machine learning, which is, of course, we are now understanding the math. We are now understanding how a neuron really behaves, right? So I'm going to talk about that in the coming slides. So one is definitely the machine learning aspect. Then there is data. There are so many sensors available. There is so many different avenues of collecting the data. The fast computing, chips are evolving. NVIDIA is an example of that. And then there is a seamless open source architectures which is making everyone, including us and also you, possible to use the work which others have done on your work. So these are the four major things basically. Machine learning, we have the networks, neural networks, deep learning, statistical Bayesian models, graphical models, and so on. So this is where we come into picture as learning. Data, when we talk about data, it's not just about data, but there are basically 5 dimensions. How much data, how fast we are getting the data, how much type of data, how good the data is, whether it is correct or not, and how much valuable is the data. So the context part is also very important. And then in the fast computing side, we have a lot of computer hardware terms like GPUs and all, which we keep on hearing nowadays. That is also contributing. And the last and one of the most important aspect, why it is so widespread suddenly and why there are so many applications coming up, is because of big companies and research institute opening up their models for everyone to use. So you have ChatGPT is an example, DeepSeek is an example which has opened up their model for all of us to use, right? So now if we go a little bit in the learning side of it, we know what enables learning. If we go into learning side of it, there are 3 basic ways in which models can learn or anyone can learn. The first one is unsupervised learning. As the name says, unsupervised. It's like, I like to compare AI learning with a kid growing up again. So unsupervised learning is a kid finding out something new and asking a question, Mom, what is this? It doesn't know what it is, but it knows that it is something new which it doesn't know. It's something different from what its knowledge base is. So that is unsupervised learning, where the system is shown inputs, gets outputs, and it doesn't know what it is, but it just knows that it's different. The second is supervised learning, which typically the way it happens in schools. So you all, I don't know if you remember for us, but for our kids or our relatives, they have the handwriting book where they have to write A gazillion times, right? A, B, 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 C, 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 so on, right? What is that happening? The kid's brain is trying to map that this action corresponds to A so many times that the model is trained. What I mean by trained is something I'll talk, but they are taught that this shape looks like A or this shape looks like S. And the third type of learning is reinforcement learning. Reinforcement learning is a kid putting its hand in fire, feeling the pain, and then not doing it again, right? So system is shown inputs, get responses. Each response is either rewarded or penalized, and based on that, the system is learning. So ultimately, with all this feedback and all this type of input-output relationships, different types of learnings can happen, which is what we do when we train such systems, AI systems. Now, the data is important, but kids can have years to grow. But for us, we don't have years to train a model or make the model ready for us to use. So whenever we look at data, we need to understand what and how much data we need. So typically, whenever we are looking for data, we need to have enough data to be arranged into 3 sets. One is training, validation, and testing. So training set is the main set of data or the amount of data which we use for training the model. Validation is something which we use to fine-tune the model, and testing is something which we say that, okay, this model is trained or not, okay? We won't go into a lot of that, but let's come to the main part, the neuron. We talked about the networks. We are now talking about neuron. Isn't this scary? Yes or no? But it is nothing but addition, subtraction, and multiplication, nothing else. It is only that. And this is where the networks part really play a role, where you are continuously repeating the same simple mathematical functions over a large amount of data, large amount of neurons, accommodated in a certain way that you get the result. So this is nothing but you have your inputs, which is coming in over here, in whatever form. You have certain functions, composition functions simply means you multiply and add, that's it. And then you have an activation function, which is nothing. but a function in which you put a value, again do addition, multiplication, subtraction, whatever, and you get an output, and that is your result. Nothing else. The basic functions that we all know are repeating in a certain fashion, which will give us the output that we want. So this is an example of how a neural network is behaving. Inputs, simple numbers. Output can be two things. One is 0, the another output is 1. 0 means I did not get, or in this case it can be -1 also. -1 means that this is not what I want, like this is not A. And 1 means that this is A. So what learning essentially is doing is, for the inputs which I am giving, which can be movement of my hand, am I able to find those parameters which for that input is giving me 1? As simple as that, right? So you see, when the model is learning by continuously repeating, it is adjusting the parameters such that for the correct input, you are getting the output that you need, right? This is one neuron. What is a neural network? It is basically a combination of this neuron, right? So I'll give another example of a neuron in action. This is something where we can understand how it is learning. Like we talked about so many features in the previous case. A has certain features and P has certain features, right? What are certain features for A? Like it has a triangle at the top. So you can see for the input A, this feature has a high value, whereas the same feature for P has a low value, correct? So these inputs and these features are something which is automatically learned through the learning mechanism, and then you can get the corresponding output over here as 1 for A, but -1 for anything else, and here 1 for P, and -1 for anything else. This is what learning is. This is how learning is happening in a neuron, right? And then, like I said, you just put these neurons in a certain stack, and they become neural network. So very interesting animation which I really like is how is that learning happening when we want to train. Let's say an example came for your prescription, which are handwritten. If we have a case where you want to digitize handwritten prescriptions, what you're trying to say is, I want to understand what this character is, right? And I want to label it with a particular digit or an alphabet or something. So in this case, what happens is, this is how the training happens. You have certain set of neurons organized in certain layers, which based on the input, which can be different features or different inputs, can go all the way to the end. And I don't know if you can see, but this is basically 0, 1, 2, 3, 4, 5, 6, and so on. So if that neuron gets activated or gives a high, which is 1, it means that it is that character. So you can see that even though we are giving 5, you are getting 0 activated, 2 activated, 5 activated, 6 activated, 8 activated, 9 activated. So is the model learned? It is not learned, right? So what happens is, you give a lot of this data so that these parameters get adjusted in a way that only 5 gets activated at the end. This is what is learning all about. So once this is learned,
if I may add something there.
Please.
So if you wanted to make this example slightly more complex, right? So the context of the problem is 0 to 9, right? And it has to identify that scripture which represents a 5 to a 5. Now imagine if I would have just limited it to 26 alphabet, A, B, C, D, E, F to Z. It could have potentially identified it as an S, right? Everybody agrees? So the context matters a lot. What is the context you're using this problem statement is? Now, let's go to the prescription world. In prescription world, we have no constraints. There can be numbers, there can be alphabets also. So now it can get confused so as to whether it is an S or 5. Now what becomes important, whether it's an S or 5? We often do that, we could do that mistake as a human also, right? O or 0, 5 or S. So what could become important? Any guesses, like other features? Perfect, yes, so units. But then what are you doing there when you're looking for units? You're looking for context neighboring context. So let's say if it is coming in the middle of, let's say you are very confident that the scripture is followed by T-A-R-T. So start is a word, right? So you're very confident that this is S, not 5. But exactly as ma'am said, if it is followed by mm or mg, then you're very confident that this must be a number because it's followed by milligrams. This is exactly where, as a human, when you're thinking context, these will now start becoming features, right? So when you go into the prescription world, the complexity of the solution is improving. Now, instead of doing one at a time, you're also taking off context of neighbors also to make it slightly better. But
Yeah, definitely. And we will come to that even more when we talk about that different types of networks which are there. But if we say that this model is trained, the output will look something like this. You have a picture in which each pixel can become an input, and that each pixel will have certain intensity, whether it is black or white, and then you have a spatial arrangement. So when all of this is put as an input and passed through a trained network, which means that I know the weights and all the parameters of this, it only gets highlighted at 7. This is what a trained model looks at, and this is what our role as building models is to do, right? To get that right output. Yeah. So if I think this slide which Gaurav already explained, so I won't go into deeper aspects of that, but basically that is how learning was essentially happening. If we talk about networks, the example which we saw is like convolutional neural networks. So you don't have to worry about the name, but what you have to understand is why there are different networks. Convolutional neural networks are good when you want to work with spatial data. And the biggest example of spatial data is images, right? So if you have an image, like the way you are able to process this screen right now is at this given time, you have data available on this corner, this corner, this corner, and everywhere on the screen. This is your spatial data. So convolutional neural networks are able to do that. The second type of recurrent neural networks is recurrent neural networks, which are able to process information across time. How you are able to listen to me is you are trying to process the words in a sequence. That is time, that is temporal information. So that is where you have, whenever you want to process with temporal information, you work with RNNs. And the third, which is I think all of our favorite, is ChatGPT, that works with transformers. Why transformers? Because transformers is something which has the ability to work with spatial as well as your temporal awareness. So it works in both dimensions. So that type of networks are called transformers. So these are just certain terms that I think will help us identify which type of models are needed for what type of problems, right? And then just a little bit more generic information on where the world is going today, which is basically towards larger language models or large language models. And that is where generative AI is coming, wherein it can generate images, it can answer questions, it can, like DeepSeek, like able to think, is able to tell you why something is happening. It can do automatic captioning, can do object recognition and whatnot. This is where the world is going in generative AI. And if we look at some of the models which is making, or some of the companies which is making this possible, the biggest one is OpenAI, then we have Google DeepMind, we have IBM, which Gaurav gave an example earlier. We have Meta, of course, Microsoft, NVIDIA. All of these companies are now being able to capitalize on the data which is available and the large compute power which is available to bring out a lot of Gen AI models which can do wide variety of aspects. But what needs to be understood as a basic functionality of Gen AI models is they work with data or the type of information which we can understand, which is language, right? So that is why it has become suddenly so powerful. Otherwise, we had algorithms which worked with data in terms of decisions, but we couldn't interact with them. So that is why NLP or LLMs are becoming so more popular. But you have to understand, even in that aspect, you need to break it down. That is where the context comes into picture. That is where the domain comes into picture. You have the documents, you have to do tokenization, removing stop words, stemming, normalization. All of these are still parts which needs to be done, but the beauty is that all of this happens automatically because there is large amount of data which is available. Yeah? So this is, in case of healthcare, we definitely have different applications like clinical documentation, which automates transcription and analysis of healthcare providers' notes, disease prediction and diagnosis, something which we have looked at an example as well. Patient engagement, where chatbots can be used, and virtual assistant for patient queries and appointment management, sentiment analysis. So many applications are also coming up. So just giving a background of where all this can be used and what goes behind all of it is nothing but networks of neurons which act like our brain. That is what is really happening. So before we go to the next part, let's play another quiz. Yes? It will be based on something which I just talked. So let me go to my library and the neural networks quiz and host live, and we know what to do from here. After this, we'll move on to the last part of this talk. So are we ready? Some exercise.
The setting.
Yeah. So we do the same thing. Either we can go, yes, we already have that. So we can go to the game pin or just...
This is the last quiz of the day. So whoever wants to win, this is your last chance.
I want to see if the names repeat. So I already have one. Mogambo coming back.
Yeah, I think Simba also came back.
Simba also came back. Pushpa also came back. And Nana Patekar just entered. Dozy is here. Dozy has to be here, right? Take another minute.
So 25, 26.
Anyone else who is waiting to join? You raise your hands, otherwise we can go ahead.
Should we wait or?
Okay.
Okay, we can go ahead, I think.
All right. So we'll start. Okay. Okay, wait. People are still joining. All right, so this time, thanks to the comment, we have options on your screen itself. Okay, so first question coming up. What of these is not a property of neural networks? Reconfigured continually, fixed and unchanging structure over time, dynamical patterns of activity, complex network of networks.
Not a property.
Not a property. I think I gave longer time here. That's the fun part. Right, waiting, yeah. Okay, we have answers. It is fixed and unchanging structure over time. The whole point of networks is to learn with continuous information coming in. So the whole aspect of networks is it can be reconfigured continuously, it can capture dynamical patterns of activity, and it is a complex network of networks. If this is what it is, there's no point of learning at all to happen, right? And I can see most of us have been able to identify that aspect. So let's look at KSP is on the lead. Okay. Next question. Why is validation data set important? I don't know if we covered it enough. This is a real paying attention game, no? So either to fit and learn model coefficients, used to tune model parameters, see which model is most accurate, never used in model training process, only used for evaluation, not a part of learning. For 1,000 rupees. Not really. Okay, you can just answer. Waiting for one more. Okay, so most of us got it. It is used to tune model parameters, see which model is most accurate. It's definitely for that. This fit and learn model coefficient is the training data set. Never used in model training, only for valuation is testing. This is validation, and definitely it's not a part of learning. All right? See life, once you're at the top and then you're not even on the leaderboard. 2 more questions. What is reinforcement learning? Right, remember the 3 types: supervised, unsupervised, and reinforcement. Right, waiting for a couple of people. You can always guess, you know. That's what neural network does until the guess is right. All right, so 21 of us got this correct. Parameters are adjusted to bring system to closer to correct output is valid for all types of learning. That is essentially what learning is. But when we go for reinforcement learning, it is basically you have a reward or a punishment or an unreward or some action which is relevant to the output. That is where this comes into picture. All right? I think this may change the scoreboard. Not really. Okay, Mogambo is in. Rahul is the highest climber, up 9 places. Congrats, Rahul. The last question. Which of the following has both spatial and temporal awareness? This should be fast.
This is an easy one.
This is an easy one, yeah. Waiting for a few more people. You can always guess. "20 seconds. How many of you feel you got this correct? Raise your hands. 10 seconds. 5. Transformers. Convolutional neural networks can only do spatial information processing. Spatial means in a space, not across time. Images are examples of spatial processing. Speech is an example of temporal processing, time-wise, okay? So transformers is the correct answer. So let's see if this has flipped the scoreboard or we still have nanoparticle at the top. Congrats, Orion and Mogambo. Yeah. Can nanoparticle stand up, please? Let's give him a big round of applause. Congrats. So moving on to the last part.
So we're towards the business end of the session. There are two segments that are remaining right now. One is we're going to talk a little bit about the results from the AFib. I hope everybody remembers the AFib problem that we had taken on, the features that we had developed for entropy and irregularities there. And then the last part is essentially the best practices overall in general for handling machine learning solutions or evaluating machine learning solutions. So, as Vibhor already mentioned, that there is training, validation, and testing data. But when you read machine learning guidelines from the FDA, Food and Drug Administration in the US, they sometimes call validation data also as tuning data. Essentially, training data is when you give a lot of data to a model to understand, to adjust weights, to learn, and to essentially have a model in place. Validation data is something that an engineer uses to check how is my model performing. Right? So the thumb rule here is very simple. Anything that the model has access to and the engineer has access to is called training. Anything that the model doesn't have access to but the engineer has access to, because the engineer is giving that data and seeing how the model is reacting to that, is essentially your validation data. And what both the engineer and the model does not have access to is the testing data. So this is your quality department, or this is your final department in the organization, or the final check that is happening without the bias of an engineer and without the bias of a model is the testing data. So finally, if you're going to review any sort of results, they cannot be on validation data. Why? Because an engineer can understand, okay, my model is not performing well for this data, let me tune the model a little bit. Let me tune the features a little bit. Let me do this, let me do that. So they can play around with the models, they can play with the features until they get the best results on validation. But testing data is something that the engineer hasn't seen yet. That is the real performance in the field. That is the real performance in real world on how something would perform. So now, when you read research papers or when somebody comes to you with a solution, you have to ask them, the results that you're showing me right now, is this validation or is this testing? Is this tuning or is this testing? And good principles from machine learning, the guidelines given by Food and Drug Administration, FDA, as I mentioned, and also ICMR, do contain this as well. So essentially, whenever we submit anything to the regulatory body, we have to submit the testing results, the final, the real world representation of the results. So now we are at we trained certain models for the features that we essentially showed for you for the AFib case. So everybody remembers entropy and everybody remembers the PNNX, where we said we are quantifying irregularity, and because the electrophysiologist told us we are looking at irregularity of irregularity, and that is where we essentially got some results from it.
One curious question though. So in this example, in atrial fibrillation, we spoke about feature engineering. And we also described 3 features, right? PNNX, entropy, and second degree entropy. We did not do that for that neural network example, right? There was no feature engineering. We just fed it 7, 7, 5, 5, 5. So just to touch upon that, why do we do that? So there are 2 concepts, school of thoughts. Yeah. here. So what we are doing here with the AFib example is this. So we have data, we have feature extraction like we did, and then we pass it to an algorithm so that it can then classify. So normal and AFib in our case. This works well when you have fewer data points, because right now, if you remember in the problem definition, we spoke about 10,000 data points. That's in the data science realm, 10,000 data points is nothing, it's very less. But in the deep learning domain or neural network, when you're talking about images and all, it's big data, it's millions and millions of data points. So there, it is okay to take an approach where we don't do feature engineering. Instead, we just feed enough data to the network, and the network itself does the feature engineering and learning both. So it is engineering features, learning from it, and then doing the classification as well. Just a difference between the two approaches. Yeah. Coming back to the modeling that we are doing today. So this style of learning, which is not neural networks based, there are some popular techniques to do it. So there's one called logistic regression. You can think of it as just the scatter plot that we saw, right? We're trying to find a separation between these two classes. So for example, normal and AFib. So try to find a separation between the two classes using the features that's been fed. That's just logistic regression. Then there are support vector machines, which you can relate to the malignant and benign scans that Gaurav spoke of, right? So here we are trying to find a plane that separates the data set. That's called support vector machines. And then you have decision trees. These are fairly simple to understand. Think of these nodes as the features that you've engineered, and these values as what the model needs to learn. So here we are thinking about low risk, high risk for heart attack. So you can imagine that age, weights, whether the person is a smoker or not a smoker are good enough features to capture and to classify. This would also be how a clinician would categorize someone as low risk or high risk, right? So if you feed in enough data in a decision tree type model, what the model tries to learn is what this number should be. So what are these numbers? So age. At what age should I start looking for whether that person is a smoker or not smoker? In what age group should I straight away say that this person is low risk, and so on? And then when do I check weight, and what weight threshold is concerning, and so on? There is another class of algorithms which is a group of models itself. So instead of a single decision tree, imagine that you have multiple, each makes a prediction, and then you combine it through some voting, and then you get the final one. So for example, you feed in some image of a fruit. This one, using its node, says that, I think that fruit is an apple. This model says that, I also think it's an apple. This one says it's a banana. So then there is like a majority voting. And then finally we say, two of them have said apple, one says banana, we'll go with apple, and that becomes the final class. And because these are a collection of decision trees, such models are also called forests.
Also, can somebody, has everybody seen Chak De India? Does everybody remember the last scene when he has to tell the goalkeeper that which side is going to come? So what is Shah Rukh Khan thinking in his mind? The hockey stick is in certain angle, the leg position is in certain thing, and he's thinking, okay, she's going to hit left because of the leg position, she's going to hit right because of the hockey stick position, but then this is contrasting. Oh no, she's going to hit straight. So there was a process of thinking that Shah Rukh Khan is explaining there, that my leg is behind, okay, so I'm going into this decision tree. But at the same time, my stick is here, okay, I have to go to this decision tree. So there is a natural example in Hindi cinema that you can think of, that through decision tree process, Shah Rukh Khan is arriving that, okay, the Australian player is going to hit straight, And that's why he tells his goalkeeper, stay there. Luckily, his prediction came true as well.
There's also another class of models that are called boosting models. Because here, you remember in the decision tree, each tree, or the forest example, each tree was independently making a decision. So one said apple, the other said apple, and the last one said banana. Here, also we have a group of models, but they work collectively. So there is one model. So imagine that this is what the model is trying to do. It's trying to hit this goal. So it has to reach here. So there is one model that's covering the most distance. It's reached till here. Now the next model also doesn't have to start its journey from there. The next model tries to go a little bit closer. Then the next one a little bit more closer. And then it can go both directions, and eventually we have a group of models working on top of each other till we reach a desired outcome. Okay? So, such models are called ensemble models, gradient boosting models. And neural networks we've already discussed. Yeah. Now, because like I said, in this example, we have very few data points, we'll not start with complex neural networks. We will start with simpler models. So we've tried logistic regression. Vibhor also mentioned that there are frameworks that exist now which make it easy for us to quickly implement such models. So this is an example where just with this little bit of snippet of code, we were able to train a logistic regression model that gave us very good performance, like accuracy of 96%, sensitivity 95, specificity 96, so on. You had something.
Correct. So quickly understanding, can you go down? Quickly understanding this part here. So this is a very important part. I hope everybody understands a confusion matrix. So what a confusion matrix is that, okay, it says it has 4 things here because the classes are 2. So what it's essentially saying is, how many of them are actual AFibs that I predicted as AFib? So this is my correct zone, right? True positives. How many are actually normal and I predicted them normal, right? So these are my, again, correctly predicted ones. But how many were actually AFib that I predicted as normal? When I say I, the model predictors are normal, these many. And then how many were actually normal, but the predicted ones were actually AFib? So here, we missed identifying AFibs, and here we found extra AFibs in normal ECG strips. Now, for any machine learning model to be good, this diagonal needs to be strong. So accuracy would be defined as how many total correct predictions that you did divided by the total predictions that you did. And that number comes out to be 96%. Right? So 96% of the times, you were able to predict the correct class, whether it was AFib or not AFib, basis this model. And then you can explain sensitivity and specificity as well.
And so accuracy, just repeating, sum total of this diagonal divided by all points. Sensitivity will be this, which is your true positive, divided by this total. So all the actual AFibs. So 3730 divided by the total of this. Specificity will be the same thing done for actually normal. So out of the total normal, how many did we get? So this value divided by the total here. There is another metric that in this problem statement we are not tracking, which is precision. So these numbers that we spoke of, sensitivity and specificity, are focused towards what is the actual value. So out of the actually AFib, how many did we get correct? Out of the actually normal, how many did we get correct? But precision talks about model's precision. So whenever model is saying AFib, how many were actually AFib? So that becomes this column, precision. So if 3730 plus 305 is what the model predicted as AFib, how many were actually AFib? These are just to show you that you can train more models with that, with this data using simple tools like sklearn. And here too, we see good accuracy, sensitivity, specificity. This is a decision tree example. A random forest, which is a collection of different decision trees. Yeah. Now, from all these examples, we saw that logistic regression and random forest came pretty close. For example, random forest gave us accuracy 96, sensitivity 96, specificity 95.9. Our goal was 96%, so very close to our final goal. So the next step is, if you remember at the beginning of the session, we'd spoken about optimization. So when you start training a model, the first iteration will not necessarily be the first and the final model, the best and the final model, right? So there's always some bit of tuning that's needed further. So this is where there are parameters like this that we can tune. Just if you're curious, n estimators is, you can think of it as just the depth of the decision tree. So if you are talking about branches in the tree, how many branches and how deep do you want to go in the branches? So if we play around with that, with the random forest, we are now able to meet all of our targets. So accuracy 96, sensitivity 96, and specificity 96. Yep. Just some more trial and errors. Yeah. Here we've just listed down a few approaches that you can take for hyperparameter tuning. And then now, okay, we built this model and then it gave us all the, it hit all the goals that we had, right, 96%. So what do we do next? So if we're building something that has to go and get deployed and actually be used by an end user, there's always room for improvement. So even if we've met 96%, can we look at those false positives and the false negatives? Can we still try to tackle those as well? Just because we've hit 96% doesn't mean that we stop work on it, right? There's always an iterative process of upgrading models again and again. So that is one thing that we can do next. We could also look at domain knowledge to see if there are more features. We stopped at just 3 features. Why do that? Maybe there are better, more nuanced features that can be introduced. Similarly, maybe there are more data sets to include. This is just one database coming from MIT BIH. Maybe we can get more diverse data and check how the model works there. We spoke about sensitivity and specificity and understood what it is through the confusion matrix, right? This is just an example to make it more relatable. So here we have a system that is trying to detect thieves, okay? Now, imagine that there are 100 occasions of, say, thieves, or that's maybe a little too much, but imagine that in this scenario, we do not want to miss a thief, right? We want to always catch a thief. Maybe we will give a few false positives. Maybe it is possible that a mosquito will sit close to the camera and then we detect this, the mosquito to be a thief. I am okay with it because my point is not specificity. It is not that I don't want to ever tag a non-thief as a thief. My point is that I always want to catch a thief. So if ever there is a thief coming in that frame, I want to get that right. So sensitivity is what is important in this system. Compared against this system, it is a system that's trying to identify whether a content is child appropriate or no. So imagine that there are 100 child appropriate channels, okay? My goal is not that I want to catch all 100. Maybe the system is able to get 98 child appropriate and miss 2 channels. It's okay. There are 2 child appropriate channels that my television is not showing. That's okay. But what is absolutely not okay is if something is inappropriate, that should not get tagged as appropriate. So specificity is what is very important here. So it's okay if I miss a few child appropriate channels, but I should never mistag an inappropriate channel as appropriate.
So, what is our goal or what is our job as technology providers when we build these, right? What should we be transparent about? So there are 4 areas where I think we have identified where technology companies, researchers, and solution makers should essentially ensure. First, communication of limitations. Any system has some sort of bias. We spoke about specificity, sensitivity. We should talk about what the system is engineered to do. The best way to speak about this is through results, right? So for example, let's say there is the AFib model that we developed, right? We should talk about what the data is built on. Like for example, MIT BH data only contains data from Americans of a particular age group. So then that model should only be supposed to be in that particular demographic, in that particular area, right? And that essentially is communicating the entire limitations that this is what we know, this is what we don't know, and these are the limitations amongst that. We also should balance data set. So different ethnicities, different geographies, different areas, different comorbidities, for example, right? So is there any other comorbidity that affects AFib, for example? Should I have that in my testing set? Should I have that in my validation set? Should I have that in my training set or not? So balancing all of these data sets is very, very important in terms of identifying that as a clinician, you know that if you're trying to build an XYZ solution and there are these comorbidities that definitely affect it, you should demand that in your training and validation set, and testing set, you should have representation of real world demographics and the comorbidities in that particular manner. And then most importantly, in the next slide, we are going to talk about bias. Machine learning systems are very prone to bias. I spoke about how my niece identified a penguin soft toy as a Kung Fu Panda, right? I'm going to show you something in the next few slides that is more serious than that. But it is a result of bias. And how do we remove that bias is something that the imperatives of the technology provider and at the very least communicate about that bias that being possible. From a healthcare perspective, AI is not autonomous right now. And I don't see a near future where AI will be autonomous in healthcare, where AI will start taking decisions, AI will start treatments and things like that. It will not happen, right? AI is always assistive to humans, assistive to clinicians, nurses, healthcare professionals. And that's why there is a layer of humans that are verifying and making sure that yes, this is the recommendation, but as per my judgment, I will do whatever I deem necessary for the patient, right? So as a job of the AI is to err on the side of caution, right? And that's why we say for screening solutions, for example, high sensitivity. Do not miss a single patient that would have had that condition. Let's say if you're doing large scale cancer screening, right? The word screening itself means that identify most of the patients that are suffering from that particular ailment. You may identify a little bit of extra normal people as the category as well. And then that could be later filtered out by the human before giving the treatment, right? So from our particular perspective, because AI is not autonomous, there is always a human layer. The AI solution should be built to err on the side of caution because there will always be errors, but can we engineer the system to error on the side of caution? This is about bias. Bias can do a lot of harm, by the way. These are initial models, face recognition models that Google and Facebook had built very, very early on, right? This is way before even the pandemic as well. And there was an outcry in the US because in somebody's phone, Google identified their friends as gorillas. And these were African American people. Now, can somebody think of why would that happen? Why would that happen? Why would Google's model identify these black African Americans as gorillas? Exactly. So when Google started building facial recognition algorithms, in their training set, there were only white people, right? When they were building that particular set, they did not balance the data set for all ethnicities. In the US, there are many ethnicities, right? So there are Asian Americans, there are African Americans, there are many people there. But they only focused on the white people in their database. So, and they had a lot of animals also in their database, right? So in absence of data, the model found because of the darker skin, the people being closer to gorillas rather than actually people, right? And that there was a huge outcry for that. Google rebalanced the data sets now, and now they make sure that any particular model that comes in facial recognition is actually balancing for each particular, how the real population looks like, how the makeup of the real population is. The second case for bias is not even machine learning related, and we all went through that. During the pandemic, there are multiple studies published now on how pulse oximeters failed Africa. Pulse oximeters do not work very well for darker skin. For everybody, I think, knows how pulse oximeters work, right? There is an LED, it is passing light through our fingers, and it is identifying how much saturation and desaturation is happening with every heartbeat. Now, they don't work perfectly for dark skin. And they cannot catch hypoxia events very efficiently for dark skin. They overestimate SpO2 values for dark skin, right? And in Africa, many deaths, many ICU transfers, many late identifications were attributed to faulty working of pulse oximeters because technology was built for the Western markets first, right? So bias, because can do a lot of harm. And that is something that we must be very, very careful while we are building any sort of machine learning solutions, because machine learning solutions completely are dependent on data. Whatever you feed, the answer would be very similar to what you feed. So, but when you zoom out of it, and when you think about it, that machine learning solutions require a lot of data. We spoke about it. 10,000 data points seem very less to a machine learning engineer for building an AFib model, right? She wants millions, if not billions of ECG strips, right? So we need a lot of data. I spoke about that. We need to cover for bias. So we need many variable amount of data, right? There should be variance in data. I should have data for all sorts of population. Isn't that true for our country? Right? The length and breadth of our country, 1.4 billion people, different ethnicities, different backgrounds, different socioeconomic conditions, right? Different regions, different food habits and things like that. Where to get best amount of variable data apart from this country? And the sheer size of the data, we can have humongous amounts of data with us. We also have an amazing healthcare expertise. The Indian healthcare system is known everywhere for the quality of clinicians, quality of healthcare that our country has. We also have a very good IT team or IT system in the country, right? We have some of the best machine learning engineers, some of the best software engineers that are out there. In fact, so well that they go out of the country and work, but there are a lot of good people in the country as well. We are working on a digital health infrastructure as well. UHI is going to come in, ABDM is starting. A lot of EHR and EMR penetration in hospitals is increasing day by day. So digital records are increasing as well. Government has identified AI and particularly healthcare as a strategic area for sure to invest in. And we are known for cost-effective solutions, our focus on cost-effective solutions. So if we have to say that, okay, we are at a certain level of healthcare quality at cost right now, and are we ready to use technology for further healthcare optimizations and cost-effective healthcare? We are, as a society, we have shown that, right? So we are also ready to adopt technology as well because of all of this. Now, all of this combined together, don't you think we should be a leader in global health AI, right? There will be an AI in transportation, there will be an AI in finance, there will be an AI in weather modeling, and there will be an AI in healthcare also. But with all of these things involved, shouldn't we be the global leader in healthcare AI? We have the biggest amount of data because we have the biggest population. We have the most variable data because that population is spread across and have different backgrounds. And we have all of these as well. We have the healthcare expertise, we have the technical expertise, we have everything in place. But there are still things that are, this is the potential, but there are still things that are stopping us. And these are the things that are stopping us. Mayo Clinic in the US has more data, digital tag data, than all hospitals combined in India together, right? Because their level of digitization storage began decades ago when a person is born in Mayo and then being tagged for every single diagnosis, every single treatment, every single procedure that they've gone through, all information is being captured throughout. So you have longitudinal temporal data of an individual over a long time. Okay, this person finally died of an heart attack. They can actually go back and see when was an ECG done, what was identified in that, When was an echo done? What was identified in that? Can we actually build an algorithm that will benefit a person coming next? They have lots and lots of data. So having data is not just the superpower, but having tagged, structured data is the superpower. And this is where we lag today, right? This is where the penetration of EMR and EHR matters, because having that sort of data, having devices that capture longitudinal long-term data and stores it digitally with context is very, very important. Having data is having potential but not having real value. But having structured and tagged data is the real value that can. Is our infrastructure ready to talk to each other? Everybody is building their own EMR, HIS, everybody is building their own protocols. Can we all agree on a single protocol, right? Is that something that we need to look at? Tech adoption is amazing, but is it really good throughout the country? Can I pick up a tier 2 town or tier 3 town? Can I pick up a public hospital? Would tech adoption be very good there? Can things improve? Yes, there's a lot of scope for improvement. And are we collaborating enough? This workshop and this session is definitely an example of collaboration, and I hope we can do many, many more beyond this. Not just as a session, but now a two-way communication in terms of, oh, this is a problem statement in my mind, can we build a solution together or not? So are those collaborations happening or not? And is enough funding and investment going in those particular areas or not? And also, is the regulatory framework picking up or not? AI is very new. AI is evolving faster before our regulators can actually think something. So there have been guidelines by SAMR, there have been guidelines by FDA, and people are moving in that direction, but AI is evolving much faster. So these are areas where if we master these, and if we control these 6 variables, the previous slide that I presented can actually become a superpower, and we have a real chance to become the global leader in health AI. And we have an example here for, so Professor Vibhor comes from IIT Indore, and we've spoken about that. And it's a technology first institute. In the name, you would essentially see Indian Institute of Technology. And then I've been to the lab where Vibhor works, and I was shocked to see the level of instrumentation and medical technology that they have internalized and focusing on digital health solution is commendable. So Vibhor is going to show a quick sneak peek of that lab.
So this is the center which we have. So basically what we have done is we have created a physically simulated ICU setup itself, wherein we also have a patient simulator, which can do a lot of different aspects similar to a patient. But more important than that, we also have all the equipments which are basically available in ICUs in our laboratory, so that we can devise mechanisms to capture that data. We also have on the left side, if you can see, a big machine which is a physical lung simulator, which can simulate a lot of different type of diseases. So what we are trying to do is, rather than waiting to get the data from the field, which takes a longer time and is much more restricted, we are trying to get the initial models developed through the simulated physical simulators like lung simulator, heart simulator, brain simulator, and so on, put together in a virtual or simulated ICU, get the data and start with the model, which can then be adapted from real life data and made better. So this is something that we are doing at the Charak Center, which is a center at IIT Indore for digital healthcare.
So, and I don't know how many of you noticed, but only engineers can name the lung simulator as test chest. That was the label on the lung simulator. So what next? I think we're towards the end of the session. We would love to discuss ideas with you one-on-one or in this forum as well. If somebody has any ideas from your day-to-day practice and is really interested in that, we can help you devise a strategy for that. And if it's very interesting to both of us, we can actually collaborate and work together as well. IIT Indore, the center, digital health center, the Charak Center is also open for collaborations. They frequently collaborate with AIIMS Bhopal, AIIMS Delhi, and other hospitals as well. And we would love to hear your ideas. But before that, if you want to read more, this was just a beginning. And as I said in the beginning, that this would not get you to start coding from tomorrow, which was not the objective. And this would also not make you a master of machine learning from tomorrow. But if you want more, these are some books that are for artificial intelligence, particular to healthcare. The middle one is something that I really love. It is written by a cardiologist who understands machine learning really, really well. There are also some courses. So if you want to try some hands-on on coding and put us out of our jobs, then these are some courses that you can essentially look at. These are open courses. You can also, I think, do them for free, but you won't get the certificate. But if you, I think, have a membership with Coursera, then you will get a certificate as well. And these are some good courses to give you initial hands-on coding knowledge for machine learning. And these have some real-world examples also where you work on them yourselves. So yeah, ending with questions here and hoping for an interaction session. Any questions or anything, please? So you're absolutely correct, sir. So one of the biggest principles in machine learning that we identify, or sorry, we essentially focus on is de-identified patient data. So no machine learning solution requires personally identifiable information of a person. So PII, personally identifiable information, is an information that can lead to your identity. So it can be a phone number, it can be a home address, it can be your name, it can be your email, right? These are something which we call PII. So if I know your name and if I know your workplace, I will be able to get your identity. If I know your name and if I know your phone number, I will be able to get your identity. So no machine learning solution requires that data. And therefore, for whatever subject or patient data that we use in machine learning algorithms has to be de-identified. So we don't really know who the patient is. We just know 70-year-old male or 65-year-old female or suffering from XYZ comorbidities had these events. We wouldn't know their identity. So privacy is definitely taken care of there. Any good solution provider or any technology leader would inculcate those best principles into the part. And yes, we need to be very careful about information security management systems. There are global guidelines out there. So there is HIPAA guidelines. There is also ISO 27001. There is GDPR. There is SOC2 Type 2. There is high tech, high trust, many guidelines, many certifications. So whenever you're working with a company, please ensure, or a solution, please ensure that they are compliant to some of these for sure, right? So for example, our company is certified for ISO 27001, SOC2 Type 2, HIPAA, and we are going through our certification for high tech and high trust right now, right? So these are cases which is very, very important point, but there are already global guidelines and measures in place. If somebody follows them, we are good to go.
I only hope that before starting the session, I would have used AI and told how many to start with delegate. At the end of session, how many delegate would have been here actually.
That's a very, very good use case for them.
So that we can plan the strategic, that we can tell the vendor and arrange the food and accordingly. I hope most of the things are clear. The idea of this session was not that everybody should start using this problem question and make an AI tool, at least to sensitize you that yes, in your practice, when you wish, you can use this complementary to your clinical skill and judgment actually. That is the idea. And if you're more interested at any point of time, you can contact all these 3 expert people to develop your tool or develop your artificial intelligence and use in your clinical practice, not to replace your clinical judgment, neither to replace your clinical examination of the patients. Before I wound up, I really appreciate and I request Dr. Divya to just felicitate Mr. Gaurav Parachi. He is a C2 and co-founder of DOSI.
While we do that, we also have a feedback form. I would request everybody, please give us feedback on how we can improve this course. And also, there would be certificates waiting for you outside from IIT Indore, from DOSI, and from the Charak Center and Royal Academy of Engineering for this particular session.
Yeah, Gaurav, please. This is from a token of appreciation from Apollo Hospital. I request Dr. Dulera sir to just felicitate Ashwathi Nambiar. She is a data scientist. One second. I wanted to take a brief shoot. I request Dr. K.V. Sima to just felicitate Dr. Vibor Pandari, please. Yeah, and thank you everyone and your relatives who asked, matlab you missed you and you spend your time today, Saturday evening here with artificial intelligence and hope in future, if everything goes well, we'll do more seminars and CME to enlighten about this artificial intelligence in clinical practice. That's all. I'll sign off. Thank you.